Alright, so now let's finish with the final video of our lovely EKG series, where now we're going to be talking about step number 9, the final video where we talk about step number 9 of our EKG 9-step search pattern. Alright, so to revise one more time, one last time, we start with assessing for the heart rate, right? And you first assess whether the rhythm is regular or irregular to know if you're going to calculate the heart rate for a regular rhythm or an irregular rhythm. And then you check the interval. The interval of what? So we have a normal sinus beat. So you check the interval of the PR interval, the QRS interval, as well as the QT interval. And then afterwards, you check for the axis of the P wave, T wave, and the QRS between lead 1 and AVF. And then next, you check for the sinus rhythm. You ask yourselves 5 questions. One of them you already asked yourself by that point. You ask yourself about the heart rate. You ask yourself whether there's a P wave and what does it look like. What about the QRS? Is it wide or narrow? What is the relationship between the two? And whether the rhythm is regular or irregular. And then after sinus rhythm, you check for conduction blocks. The many types of conduction blocks: bundle branch, in order sinus block, AV block, and then bundle branch block. And then you look at Wolff-Parkinson-White syndrome, pre-excitation. Then number 7, after step number 6, step number 7, atrial enlargement and ventricular hypertrophy. And we said that if you diagnose bundle branch block first, then you will exclude ventricular hypertrophy, but otherwise you can check for it. And then we come to step number 8, where in the previous video we talked about myocardial infarction, STEMI and NSTEMI. Now we come to step number 9, and step number 9 is to search for cardiac and non-cardiac disorders that might give you a specific change on the EKG. And this is according to the case. This is according to the case. If you have history and examination suggestive of pericarditis, look for pericarditis. History and examination suggestive of pulmonary embolism, look for pulmonary embolism. If you have history and examination suggestive that this patient, history and examination that is suggestive of hyperkalemia or hypokalemia, for example, in hyperkalemia or a prolonged QT interval, we have a patient that takes an ACE inhibitor and a quinolone, which is an antibiotic. Both of these drugs, they can cause a prolonged QT interval, so you order an EKG, for example. Or drugs that increase the potassium levels, like in ACE inhibitors, like diuretics, thiazide, and so forth. You know, no, not thiazide, sorry, like potassium-sparing diuretics, like spironolactones, for example. So it is according to the case where you will search for these disorders: pericarditis, hypothermia, of course, if a person is feverish, pulmonary embolism, and so forth. So we're not going to talk about every single disease or every single condition that might give you a specific change on the EKG. We're not going to go through each and every single one of them. We're going to talk about the more infamous ones, where we will briefly summarize what are the EKG changes for each one. And again, if it is according to the cause, that you search for one, because in reality, you're not going to search for every single one, unless it makes sense to do so, unless it's in your differential diagnosis, unless you are suspicious that this might be a very dangerous event that's very likely to occur in this patient, okay? So step number 9 is according to the case, starting with specific cardiac and non-cardiac disorders. So let's start with hyperkalemia, electrolyte disturbances. Now, disturbances in the electrolytes, like calcium and potassium, can affect the conduction system of the heart, and specifically the repolarization of the ventricles, all right? Specifically the T wave and the QT and so forth, right? So let's start with hyperkalemia. When you have an elevated potassium levels, it can give you the following changes. The most infamous EKG change that you will see in a person with hyperkalemia is a hyperacute T wave, where you can compare this R wave amplitude to the T wave. Notice how it's just as big, if not bigger, than the R wave, this hyperacute T wave. Now, we've seen hyperacute T wave in a previous video with STEMI, and that is why we should mention that a lot of the signs, especially with STEMI, a lot of the signs are non-specific. even ST segment elevation, although this one is the most specific for STEMI, which is why it's important to always know that at the end of the day, EKG is a tool. It is there to what? It is there to confirm your diagnosis, not make your diagnosis. You must have your history done, you must have your examination done, and then following your investigation, you will confirm the diagnosis. So a hyperacute T wave, that can be STEMI, and that can be hyperkalemia. How can I differentiate? Do anything besides EKG. Order CBC, order potassium levels. Look at the history, look at the exam. Look at the drugs, the medications he's using. Then you'll know. So, a hyperkalemia may infamously present with a hyperacute T wave. But it can also present with a flat P wave. So the P wave may either not be present, or you might have a prolonged PR interval. And that's what we're talking about. Again, these signs, they are sensitive, but they're not specific. We've seen prolonged PR interval in the conduction block. We can see it in hyperkalemia. So, in hyperkalemia, another sign can be a prolonged PR interval or a flattened P wave, where the P wave is flat. It's flat, it's non-existent. Mumtaz? Another finding could be a wide QRS. Again, we're going to have a non-specific finding. You could have a wide QRS, and eventually, you can have a QRS that's so widened that it joins with the T wave and it forms what is known as a sine wave. So the sine wave, if you look at it, it kind of resembles ventricular fibrillation. And that's not actually what it resembles, is that when hyperkalemia, when it's so severe, it can lead to ventricular fibrillation. So how I like to think of it, how I like to memorize the EKG changes of hyperkalemia is in steps, okay? I memorize it in steps. So number one, you can have a hyperacute T wave. Number two, you can have a prolonged PR interval. And the P wave, you can imagine it gets stretched. It gets stretched and stretched and stretched until the P wave is flattened. Alright, so that's step number three. So you can have a hyperacute T wave followed by a prolonged PR interval, and then this P wave is so stretched out from the QRS that it causes it to be flat. Okay? So I like to think of it like this. And then at the same time, while you're stretching the P wave, the QRS is also being widened. So you could also have a widened QRS. And if you keep stretching and stretching and stretching, this widened QRS can join with the hyperacute T wave. And this can form a sine wave, which can further develop into ventricular fibrillation in cases of severe hyperkalemia. So this is how I like to think of the EKG changes in steps, okay? Number one, hyperacute T wave. Number two, prolonged PR interval, stretching each other out between the P wave and the QRS. Flattened P wave, then a widened QRS, then we have the sinus wave, okay? Or the sine wave, okay? That's how I like to think of it. So these are the EKG changes of hyperkalemia. The more common ones are hyperacute T waves, okay? And they tend to be diffuse. Now, one more electrolyte disturbance. We finished with hyperkalemia. But one more electrolyte disturbance can also present with a very dangerous EKG finding. And you'll also find it in hyperkalemia. And that is hypercalcemia. If you have hypercalcemia or hyperkalemia, they can also predispose to a short QT interval, okay? Now, a short QT interval is not as dangerous as a prolonged QT interval, but sometimes arrhythmias can occur. Not the same arrhythmias as a prolonged, but sometimes it can also be a little bit dangerous. But overall, there's another EKG finding. Mumtaz, this shortened QT interval, you can see this in hypercalcemia, and you can see this in hyperkalemia next to one another, alright? So that's another electrolyte disturbance. Hypercalcemia with shortened QT interval. Hyperkalemia, it can present with short QT interval, with hyperacute T wave, and the remaining stuff, okay? Now we finish with those two. Let's look at another electrolyte disturbance. Hypokalemia and hypocalcemia. Now, remember how we said hyper, and hyper? They cause short QT interval. Well, hypo and hypo cause prolonged QT interval. They're the opposite. So, hyper and hyper, short QT interval. Hypo and hypo prolonged QT interval. ممتاز. So a prolonged QT interval, it can lead to the development, as you know from previous videos, this can lead to the development of a polymorphic ventricular tachycardia thanks to a premature beat hopping on top of it, and this can lead to torsades de pointes, which is a very dangerous ventricular arrhythmia. So like in such a scenario, if you have a prolonged QT interval between this sinus beat and this sinus beat, if it lasts 50%, if this QT interval lasts or makes up about 50% or more of the RR interval, we have a prolonged QT interval, and it's very dangerous. ممتاز? So hypokalemia and hypocalcemia can be one of the causes of prolonged QT interval, joining with other drugs, all the antibiotics, all the anti-epileptics, all of the some of the other drugs that we're not mentioning so far. All right, they all can cause a prolonged QT interval. Antipsychotics can cause a prolonged QT interval, and you now add hypokalemia, hypocalcemia as another cause. ممتاز? Now, what about hypokalemia? Now, hypokalemia may not just present with a prolonged QT interval. It can also present with an ST depression. If you recall from previous video, we talked about how one of the differential diagnoses of an ST segment depression is that it could be hypokalemia, in which we have a P wave followed by a QRS, and then we have an ST segment depression, right? Right. Now, let me fix that. We have an ST segment depression, all right? And accompanying with ST segment depression, you know, we can have a very specific finding of hypokalemia, and that is the addition of another wave, and that is known as the U wave. So if you have a wave that's coming immediately after the T wave, and it's a bit larger in amplitude, so I have a wave that's larger in amplitude than the T wave, and it's coming after the T wave, this is known as the U wave. And this U wave suggests an abnormality in repolarization due to hypokalemia. So this is another very specific finding of hypokalemia, is that you may see the presence of a U wave accompanied with ST segment depression, and in severe cases, it can lead to prolonged QT interval, which can also then therefore it joins with hypocalcemia as one of the causes of prolonged QT interval. So hypocalcemia can cause prolonged QT interval. Hypokalemia can lead to ST segment depression, the appearance of a wave that's greater in amplitude than the T wave, and it comes after the T wave, known as the U wave. You can have a U wave plus an ST segment depression plus a prolonged QT interval for hypokalemia. ممتاز? We finish with electrolyte disturbances. Again, you look at your CBC, you'll see low potassium, خلاص, you make your diagnosis. Now, another cardiac condition, or really a non-cardiac, it's really more of an artery condition, or a thrombus condition. This is known as pulmonary embolism. Pulmonary embolism, from the name, you have an emboli that's lodged between the pulmonary arteries, all right? So you can have one over here and one over here, and you have an emboli, an embolus that's lying within the pulmonary artery. And as you know, the pulmonary artery, it's there to transfer deoxygenated blood from the right ventricle to the lungs, so they can be oxygenated. So if you obstruct the pulmonary artery due to an emboli, known as pulmonary embolism, and this emboli coming from DVT, from a thrombus within a deep vein of the leg, when that happens, that will lead to pulmonary embolism, the signs and symptoms. Now it could be asymptomatic, or it could be massive, very symptomatic, very severe. And it can lead to the person complaining of chest pain, shortness of breath, past history of pain in his calf, and all that stuff. Regarding EKG, regarding the findings of pulmonary embolism, a lot of the findings are non-specific. A lot of the findings of pulmonary embolism, they're related to the action of the right ventricle. The right ventricle having to contract against an obstructed pulmonary artery. So it will contract more and more. It will hypertrophy more and more to send more blood towards the pulmonary artery that's obstructed, increased after load. And thus, if the right ventricular hypertrophy, if it's hypertrophied, the right atrial enlargement the right atrium could also be enlarged. So a lot of the EKG signs of pulmonary embolism, they reflect a problem in the right side of the heart. So you might find on an EKG signs of right ventricular hypertrophy, signs of right atrial enlargement, because the right side of the heart has to work very hard and has to undergo changes to basically be able to pump blood against an obstructed pulmonary artery, which is obstructed by this emboli, which came from DVT. So you might find right ventricular hypertrophy, right atrial enlargement, sinus tachycardia, and that's the most common EKG finding of a pulmonary embolism. And sometimes when a pulmonary embolism is so massive, it can give us a very specific change. Unlike the one from above, unlike those three, we can have a very specific pattern on an EKG that can be seen on a massive pulmonary embolism, and that is the S1 Q3 TC pattern. Now S1, this pattern, S1, it means we have a deep S wave in lead 1. So this is lead 1, we have a PQRS, and look at the S wave, how it's broadened, it's deepened. So that's the meaning of S1. At the same time, look at lead 3. Lead 3 might have a deep Q wave. This could be normal, this could be abnormal, and according to your case. So you might have Q3. Q3 means in lead number 3, you have deep Q wave, and T3 means in lead number 3, you also have an inverted T wave. So the S1 Q3 T3 pattern, it means that in lead 1, S1 means in lead number 1, it brought in deep S wave. In lead number 3, Q3 and T3, in lead number 3, you might have a deep Q wave and an inverted T wave. Together, they make up the S1, the Q3, and the T3 pattern, which is suggestive, it's not confirmatory, but it's suggestive of pulmonary embolism, where in this case, you can do D-dimer, you can do spiral CT for the pulmonary artery to confirm your diagnosis and immediately send this patient for thrombolytic therapy. Okay? Okay. So that's regarding pulmonary embolism on an EKG. Another EKG finding could be seen in digoxin. Now, digoxin or digitalis, this is a drug that's given for people with heart failure, and it's basically its main effect is to act as an ionotrope, meaning it produces cardiac contractility by manipulating the heart's conduction system and by acting on the heart itself. Sometimes with digoxin, when you're giving it to a patient at a therapeutic level, it might give you what is known as digoxin effect on an EKG or digitalis effect. So if you ever saw a person with a mustache like mine, where it's twirly, like in this guy, this Pringles guy, you might see it's twirly. And the reason I'm talking about mustaches is because you might find on an EKG, you might find a P wave followed by a QRS, and you can see at the end of the S wave how it's going downslope. It's taking a smooth downslope, as you can see right here. So it's taking a smooth downslope. It is similar to what we talked about, the delta wave and Wolff-Parkinson-White syndrome. But in delta wave, there's a rapid initial upstroke at the beginning of the QRS. But here we're talking about at the end of the QRS, where we have a rapid downslope. And this one can look like a mustache. It can resemble the twirling of a mustache or a Salvador mustache. So this is known as the digitalis effect. And by the way, this is normal. This can be seen in people who are taking digoxin at a therapeutic level. But if people have digoxin toxicity, they may come with any arrhythmia. Any arrhythmia, my man. Any arrhythmia. Bradycardia, AV block, anything. And it's very, very life-threatening. But at a normal therapeutic level, it may give you the digitalis effect, which is a downslope, Salvador mustache-like effect. A downslope, kind of like a downslope ST segment depression, okay? Kind of like it, Mumtaz, at the end of the QRS, all right? So that's regarding digoxin. So now we finished the electrolyte disturbances, hyperkalemia, hypercalcemia, hypokalemia, hypocalcemia, pulmonary embolism, as well as digoxin effect. Now we talk about the final three disorders. Now we have a case of, let's start from the bottom. Now we have a case of something what is known as Brugada pattern. Now Brugada This is an autosomal dominant disease in young males, where there's an abnormality in the depolarization, or no, there's a problem in the repolarization of the conduction system of the heart. So if you look at V1 to V3, you might see a right bundle branch block pattern. You might see something that resembles a right bundle branch block, where there's a widened QRS and there's a tall R wave. So in the case of this one, the R wave is tall towards the opposite way. You might find what looks like a widened QRS, but in reality, this is an elevated ST segment. So you might find something that resembles a bundle branch block, but it's not exactly. You might find a broad and deep R wave that's going negative deflection. You might find a widened QRS, but in reality, this is an ST segment elevation when you compare it with the baseline, the PR interval. And you might find a T wave inversion. So if you find in V1 to V3, if you find a broadened and deep R wave with ST segment elevation, with T wave inversion, all alone, all isolated between V1 and V3, then this might be known as Brugada pattern, which is an autosomal disease that runs especially in young males, most commonly. Mumtaz? Mumtaz. Okay? Now we finish with Brugada pattern. And notice how the ST segment elevation is not convex downward like in STEMI. It's concave upwards. Mumtaz? Okay, we finished with Brugada pattern. Now, another thing that you might notice is hypothermia. Now, if a person has fever, usually these people with fever, they might have shivering. So if they have shivering, if they cannot sit still, or if they cannot lay down still for an EKG, this will produce an artifact. An artifact means there was basically a problem with the EKG machine. In this case, there was a problem with the patient. The patient, while you lay him down, while strapping the EKG legs, he's shivering. So he's moving the legs. And this will lead to a tremor artifact, what kind of looks like atrial fibrillation, but it's not. So you see these multiple waves going up and down, up and down, up and down. You see this diffusely. And this is indicative of a tremor artifact due to a person who's shivering in hypothermia, right? He's shivering. Or in people with Parkinson's disease or Parkinsonism, where they have a tremor, right? Or a pill rolling tremor. And this will affect the EKG reading. It will give you a tremor artifact which resembles atrial fibrillation, but it's diffuse. You're not able to distinguish what's going on. It's just a problem with the machine due to the patient moving too much, all right? But sometimes the patient is not moving. Sometimes the patient is not shivering. And if he's not shivering, then in a case of hypothermia, you might see that on the EKG reading, everything is prolonged and slowed down. What does that mean? It means that everything is slowed down in hypothermia. So you can think of it like this. If the temperature drops, everything in the EKG drops. So the heart rate may be bradycardia. The PR interval may be prolonged. The QT interval may be prolonged. The QRS may be widened. So in hypothermia, every interval, every segment, it can be prolonged. And the heart rate can be slowed down. It can be decreased. And that occurs because in hypothermia, everything goes down. When you have a fever, when you have hypothermia, everything in your body slows down. And that's including the heart. Mumtaz? So, this is if the patient is not shivering. If he's shivering, then another finding of hypothermia is a tremor artifact, okay? So either prolonged interval with bradycardia or a tremor artifact you'll see in people with hypothermia or in people with Parkinson's disease or Parkinsonism or people with seizures. Alright, now we finished with hypothermia. The final disorder, the final cardiac disorder that we talk about that may be seen in EKG is pericarditis, inflammation of the pericardium. The pericardium meaning the outer layer of the heart, followed by myocardium, followed by endocardium. In the case of pericarditis, due to a viral cause usually, it will give us a specific finding. And this specific finding can be as followed. It can present this patient with a depressive PR interval. So look at this reading. You can notice following a P wave, you can see that PR interval, it's depressive. This is a very specific finding of pericarditis. But as usual in the world of EKG, not every sign is specific. You need a combination of signs on the EKG plus your clinical context, plus your history and exam to confirm your diagnosis. Just please, just be careful. Depressive PR interval is specific for pericarditis, but you can see it in STEMI. You can see it in other conditions. But this is one of them, okay? So depressive PR interval may be one of the EKG signs of pericarditis. But another EKG finding that's infamous in pericarditis is diffuse ST segment elevation, with or without T-wave inversion, okay? So in pericarditis, you might have an ST segment elevation that is concave upward. You can see it's concave upward, not convex downwards. Okay? So it's concave upwards, so we have a ST segment elevation. And sometimes it's difficult to distinguish pericarditis from a STEMI. So that's why you look at the shape. Is it convex downwards or not? You also look if it's diffuse. And STEMI is localized to a specific leg, overlying the infraction. But in pericarditis, it is diffuse. So you might find ST segment elevation in all of the legs. This is a good sign of pericarditis. If it's concave upwards, a good sign of pericarditis. Depressive PR interval, another good sign of pericarditis. And sometimes you might find another additional finding is that you might find T-wave inversion, all right? And usually in pericarditis, ST segment elevation and T-wave inversion, they occur separately. So in pericarditis, if you find ST segment elevation, you'll not find T-wave inversion. If you find T-wave inversion, you'll not find ST segment elevation. So that's another way to differentiate between pericarditis and a STEMI, is that if you don't see the T-wave inversion and the ST segment elevation together, they occur separately, Mumtaz, or ST segment elevation being diffuse, or depressed PR interval being present, or all of the above. Mumtaz, all of the above with either T-wave inversion or diffuse ST segment elevation لحالهم. So this is one of the many ways you could distinguish pericarditis from a STEMI. Again, the best way to distinguish, the best way to confirm your diagnosis of pericarditis, of pulmonary embolism, or any other condition is always clinical context. The EKG is a tool. It is there to confirm your diagnosis, not make your diagnosis for you, please. If from your history and from your exam, you will know whether it's likely to be pericarditis or STEMI, all right? And with cardiac enzymes, and with whatever, all right? So that's regarding pericarditis. Either depressed PR interval, diffuse ST segment elevation, or instead of ST segment elevation, you see T-wave inversion لحالهم. They don't occur at the same time. Unlike in STEMI. In STEMI, you might have both of them. But in pericarditis, you might have either ST segment elevation or T-wave inversion, but not both of them together. Now, we have officially finished the cardiac disorders and the non-cardiac that you want to focus on according to your history and examination to search for on an EKG. We looked at electrolyte disturbances. We looked at pulmonary embolism and pericarditis. We looked at a genetic disease, Brugada pattern. We looked at hypothermia, and we looked at digoxin effect to be reassured that this is normal at a therapeutic level, not a toxic level of digoxin. And now we have finished the disorders, and now we have finished searching for step number 9. The normal EKG tracing like in led to, like we said, PQRST. Intervals are normal, axis is normal, none of these should be present. But with history and exam, you will do your 9-step pattern when searching on the EKG. From starting from the heart, all the way to step number 9, according to the case. Now we have finally finished our EKG series. I hope you benefited from it. And the only thing I have to say to finish off our series is that I'll link in the description below a website known as Harvard ECG Mave Waven. So ECG Mave Waven is a website that will allow you to test yourself in cases. There's up to 500 cases that's provided by the University of Hartford. So after finishing the video, you can test yourself on that, and you can see whether or not you're able to apply what we've learned together so far. Besides that, I hope you liked the video, and you can recommend this series if it's beneficial to you, if it was useful to you. Recommend the video, recommend the channel to anybody else. This EKG series, it applies to people with emergency medicine rotation, people with internal medicine, people with family medicine rotation, people with internship rotation. The idea here is to give you the basics. And after finishing the basics, now the best way to revise yourself with EKG, to revise yourself with chest X-ray, to revise yourself with arterial blood gas, acid base and all that stuff, the best way is to expose yourself to cases. So now's the time for you to test yourself in EKG cases, like in the description below, where I will link to you a website where you can test yourself. And eventually, you can be a master at it. And if there's anything new, you can add to it. If there's anything new, like in cardiology rotation, you can add to it to your search pattern, okay? That's pretty much it, and I'll see you later. Ramadan Kareem.